Good evening, everyone, and welcome to another continuing education webinar through our Wound Ostomy and Continence Institute. We're excited to have you again as a part of this series that we have going on called the Advanced Wound Strategies in Lower Limb Care. And this is one of our last parts of 2025, but we will be continuing this webinar series further into 2026. We have one today, of course. We'll have another one next week. And then we'll have quite a number in 2026. So do stay tuned as we continue to promote those upcoming dates. But thank you for joining us today. We're going to be talking today about the dermatological pearls to optimize leg and foot care. And we're honored to be joined again by Dr. Gary Sibbald, who's the founder and executive director of Woundpedia and the lead of Project Echo Ontario Skin and Wound. Before I introduce Dr. Sibbald, I'm going to remind everybody, it looks like you're already doing it there, but click on that chat button in your Zoom toolbar and let us know where you're tuning in from, or maybe what brings you today to talk about dermatological pearls. My name is Troy, and I'm the Chief Operating Officer for Nurses Specialized in Wound Ostomy and Continence Canada. I'm going to be helping with some of the Q&A at the very end of this webinar. So if you do have questions, click on the Q&A button in your Zoom toolbar, and that'll make sure we can collate and organize as many as possible so we can get to as many as we can at the very end of the webinar. We're also recording today's webinar, so you can go ahead and watch it back afterwards, or if you have to head out a little bit early, you'll be able to do that later on. All the webinars in this series have already been recorded, so if you wanted to watch any of the other ones back, or if you didn't have a chance to watch some, you're welcome to do that on our website at nswoc.ca. We're also going to be sending certificates of attendance to everyone who's online today. Thank you to everyone's patience to everyone who was registering for our other webinars over the past week or so. We had a bit of a delay with some of our certificates in the queue, but they should be sent out by the end of the day today. And we, of course, will be able to send today's out within the next 2 business days or so. So thank you again for your patience. We're going to be using polls today. So as Dr. Sibbald goes through the slides, make sure to respond to those polls. We'll show the results on screen as well. So without further ado, I also wanted to just thank Perfuse Medtec, who have the geko device. We'll be talking a little bit about that today, but thank you again for your ongoing support for not just today's webinar, but for the entire series overall. So let's introduce Dr. Sibbald. He's both a dermatologist and an internist with a long-standing clinical and academic focus on wound care. He's a professor of medicine and public health at the University of Toronto, an internationally recognized wound care educator, clinician, and researcher, and a key opinion leader in the field. He's the co-founder and course director of the International Interprofessional Wound Care Course, or IIWCC, and the director of the Master of Science in Community Health Prevention and Wound Care program at the Dalla Lana School of Public Health. Dr. Sibbald is also an investigator with the Institute for Better Health at Trillium Health Partners, and his leadership extends globally. He's the former president of the World Union of Wound Healing Societies, co-editor and chapter author of the Chronic Wound Care Textbook, and an author of more than 200 publications. He currently serves as the co-editor-in-chief of Advances in Skin and Wound Care. So without further ado, I will pass over the mic and the slides to you, Dr. Sibbald. Thanks for being with us again today.
Okay, thanks, Troy, and away we go. And today's journey will be a little bit different, and we are going to look at tools for identifying the high-risk diabetic foot. So we are going to touch a little bit on where dermatology intersects with wound care, assess appropriate management strategies, and because we're concentrating on leg and foot psoriasis and atopic dermatitis, and we will review the importance of sun protection and some of the things that happen when we get exposed to the sun and as we age and skin cancers. Next slide. Okay, this is your first of 5 votes. I am, and pick the highest number that applies to you and vote. So pick the highest number and let's get you to vote on this.
All right, and we'll keep it open for a couple seconds. Again, if none of these apply to you or if you're other, you can click on that and reply in the chat. So we got most people replied now, so I'll share the results with you. And it looks like we've got 37% of people are RNs, 26% are RPNs or LPNs, with 15% NSWOCC, 7% SWANs, and a mix of all the other types.
Okay, so I think this is an interesting mix. And next slide. Okay, The incidence of diabetes is increasing so that we're really looking at 2.5 up to 25% in some specialized populations as high as 50%. Lifetime risk of a foot ulcer is 25%. The ulcer recurrence within 5 years is 50%. And persons with diabetes and non-traumatic lower limb amputations, it's 70%. So this is getting into a real conundrum. Next slide. I think the other thing, and press this again, is that when we look at a person with an amputation or a neurotrophic ulcer, the 5-year mortality is higher than Hodgkin's disease or breast cancer in females or prostate cancer in males. So we're looking at a really high incidence here of mortality. Next slide. And this is the wound bed prep paradigm, and we're up around treat the cause, and we're really up at the level of preventing a wound and a person at risk. Next slide. If you're a person with diabetes with no peripheral neuropathy and no peripheral vascular disease, chance of you having an ulcer in the next year is 2%. As soon as you develop peripheral neuropathy, it goes up to 4.5. And if you have peripheral vascular disease, it goes up to 13.8. But if you have any two of the four risk factors, peripheral neuropathy, peripheral vascular disease, history of a previous ulcer, history of a previous amputation on the lower limb, the ulcer yearly incidence rate goes up to 32.2%, so about a third. And if you look at an odds ratio, it's actually 52.7 times more likely, even though there is a big confidence interval there. Next slide. Okay, here's your second question. Do you currently use a tool to screen for the high-risk diabetic foot in your practice? 1, yes, 2, no, 3, not applicable to my practice. Let's vote and let's see where you're at. And you know, there is some utility in using these tools, and sometimes the tools are more like assessment tools than screening tools. And it makes it very difficult in a busy practice to be able to do this type of tool and to come through with an answer.
Alrighty, well, lots
Okay.
of participation there. You should see the results. 53% saying yes, 32% saying no, and 15% saying not applicable.
And I think it's interesting, and congratulations to the over 50% that have done it. And I want to show you a simplified version of a tool. Next slide. And we know that 85% of lower extremity amputations are preceded by a diabetic ulcer. And every 20 seconds, somewhere in the world, a lower limb is lost to diabetes. So can we spend a minute to see if we can save a limb? Next slide. In our Guyana project, which went through from 2008 to 2013 and published in 2015, we decided the diabetic screens were complex and we needed to simplify it. And 80 patients were booked every Thursday morning, and our nurses needed something they could go around and screen the people as they were waiting for their clinic appointments. There was only one time, and it was 8 o'clock in the morning. And so the nurses had lots of time to check everybody's feet. A history, inspection for abnormality, palpate a pulse, look for a deformity, and do a monofilament testing. This is very simplified. Next slide. And this has been validated. And what happened in Guyana, and this is published in PLOS, 68% reduction in amputations. We could go back in the OR record of the Georgetown Public Hospital Corporation 43 months previous, 43 months after we opened the Diabetic Center of Excellence. We had the simplified screening tool. We had 7 satellite diabetes foot centers around the country, but the Georgetown Hospital was the only place the amputations took place. We had 15 individuals, doctors, nurses, and rehab assistants train in the International Interprofessional Wound Care course. And we got doctor, nurse, and allied health working together. The rehab people in the basement of the Georgetown Public Hospital were in the same building as the male and female surgical ward. And the most common admission to those wards were diabetic foot ulcers. And yet there was only one consult for 11 rehab people in the 2 years before our project. Next slide. Here's the screen that we decided on, and let's just have a look at it, and then I'll go through the parts of this screen.
Simplified 2012 60-second. Have you had a previous ulcer?
No.
Amputation?
No.
On exam, look for deformity, callus, blister, linear crack or fissure. Check the toe webs because there may be a crack or fissure. Look on the dorsal surface, look at the nail folds for any thickening or ingrown nail folds. Then feel or palpate dorsalis pedis, posterior tibial pulse. Do you feel this?
Yes.
Using the monofilament, tell me when you feel it.
Yes. 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 Yes.
2 negatives, we need 4 or more negatives for a positive test. Remember to do the other foot.
Okay, let's go on and look at what I just screened. The first thing is a previous ulcer. And sometimes you'll see a scar like you see over the first metatarsal head there. The second is a previous amputation, and you see one where the forefoot is completely amputated, and another one where it appears that some of the toes are missing, and there is a deformity within the examination of the foot itself. Next slide. The biggest deformity is a Charcot foot, and this is where the bone structure liquefies. It's an inflammatory response. On the next slide, the temperature can be 8 to 15 degrees higher. Usually it's in peripheral sensory neuropathy with normal circulation and trauma, which may be mild. You get dislocation of joints, but also multiple areas of breakdown within the foot. There is insensitivity in the foot, instability of the joint, redness. Usually you have a bounding pulse, swelling of the foot and ankle, and this may be caused for synovial fluid to leak out of the joint capsule. You get subluxation or misalignment of the bones that form the joint. Next slide. Early recognition, you need offloading to reduce the deformity that will result in continued weight bearing and should leave the clinic in a wheelchair because you will end up with an amputation that's preventable and you need to manage the various complications. Next slide. This is an ingrown thickened nail fold. This is a very exaggerated one, but usually you can't see the distal nail. And if you look at the distal nail, it is under the ingrown nail fold. And this is a sign that there's something wrong. Next one. Feel for a dorsalis pedis or posterior tibial pulse, as you saw I did. Often laying your hands across the foot and waiting for the pulse to come to you, not moving around and pushing in minute on minute, but being very strategic and, whether it's one finger across the base of the toes or you're feeling up higher. And the dorsalis pedis and the posterior tibial pulse is usually around the lower posterior part of the medial malleolus. And if you press very lightly, the pulse should come to you. Next slide. An active ulcer is the loss of epidermis with the dermal or deeper base. Next one. A blister may be due to friction or shear. And a blister is a fluid-filled sac. And the fluid can be serous, which is clear, sanguinous, which is bloody, or pustular, which is yellow. And you can have any combination of the three. So it could be serosanguinous, you always put the most predominant one first and then the second, or serosanguopustular, meaning there's more serum than blood and less pus than the other two. Friction is when two surfaces rub together, so the foot against the sole of your plantar pressure redistribution device or shoe. Shear is a deep source when the bones move one way and the skin moves another. A fissure was removed from this because it was very hard to tell if the base was dermal or not. And just about everybody with a fissure had neuropathy. Next. This is callus, and callus is a response to pressure. And thickened stratum corneum or keratin. And, pressure or shear may be playing a role here, but mostly pressure. And they can be painful, as can a Charcot joint, but not always. You can have soft corns between the toes, which are, if you like, in a way, a type of callus. And you have to watch for the damp and peeling skin, especially in the toe webs. And looking in the fourth and fifth toe web is often very useful. I'll come back to that later. Next one. Remember to check those fourth and fifth web spaces. And the keratin is actually broken down by the fungus, usually Trichophyton rubrum, but there are other funguses. Then bacteria can get in, and because the skin barrier is broken down, this can lead to lymphangitis and a cellulitis of the lower leg. And this can be the entry point. Next one. What would you recommend for macerated fourth and fifth toe webs? An azole cream, so that's clotrimazole or canestin, ketoconazole, econazole, miconazole, or clotrimazole, I think I mentioned at the beginning. Number 2, would you recommend polysporin fusidin or Bactroban cream? Would you recommend povidone iodine 10% solution? You might know that as betadine solution. Hypochlorous acid, which is known as Pure Cleanse or VASH, or you might know PHMB, which is Prontocyte. Which of those 5 would you recommend in the toe web? So let's put polling question 3 up. And all I see is the picture, not the polling question.
The questions are just beneath that when you scroll. So we've got lots of answers coming in. We'll wait a couple more seconds as people think of their answer.
I didn't get the polling question.
It might look a little weird because the photo's also in the polls, but it's just beneath the photo if you're able to scroll. If it's hitting looking the same for other attendees too, just scroll down a little bit within the poll itself. But we're looking like we're about 46% are saying providone iodine, 25% are saying hypochlorous acid, about 16 or 15% are saying an azole cream, then 8% polysporin or Bactroban cream, with PHMB at the lowest.
Okay. An azole cream is going to keep the area moist, and it'll treat fungus and a little bit of bacteria. Polysporin fusidin and Bactroban primarily treats gram-positives, although there may be some gram-negative, but you're not going to get drying of the web space. With povidone iodine solution, you will get drying of the web space, and povidone iodine has the best penetration with 2 surfaces of different viscosity into a biofilm, which this type of structure favors biofilm formation. And that's to the bacterial advantage, but betadine iodine is a very small molecule that penetrates the glycocalyx better than anything else. It treats gram-positive, gram-negative, and anaerobic bacteria. It treats viruses. It treats fungus, and it treats yeast. So it really is kind of your universal agent. And in this case, you're not worried about tissue toxicity because you want it to penetrate the tissue and you want to definitely kill the bacteria. Hypochlorous acid will come up later in this talk, and it's very good for helping preserve host tissue. And I think for cleansing and wounds, it's something we should think about more often. Prontosan PHMB is very good, polyhexylmethylene biguanide. It's very good at killing methicillin-resistant Staph aureus, but it's not as good as Pure Cleanse for and BASH, the hypochlorous acid. Next slide. But both of those are number 4 and 5 will dry. And this is the therapeutic index. And you should look this up, but this is looking for toxicity data that we did with the late Greg Schultz and some medical students and residents from University of Toronto. And what we saw was that hypochlorous acid had the highest therapeutic index for E. coli, Pseudomonas, and Staph aureus. And on the top of that, the higher number meant that it protected host cells over the minimal bactericidal concentration. Next slide. Are all these fungus? One of the problems is there are 22 conditions that can mimic fungus in toenails, and not all of these are fungus. Next slide. Here we see the patterns of fungal nail infection. The most common is the distal lateral subungual, and this is where you see a wide streak at the distal part of the nail, and it's more narrow as it gradually grows proximally. In the bottom right slide is a whole plate onychomycosis. Onycho is nail and mycosis is fungus. And this is when you get very advanced disease. And then sometimes you can get secondary molds like scopulariopsis in there. The left bottom is the next most common. It's superficial white, and it's when a yeast and occasionally Trichophyte megaprophytes can invade the surface of the nail. And this one you can treat topically, whether you use Jubula or which is efinaconazole, those are the drops, topical that'll penetrate the nail, or even the azole antifungal creams would probably eradicate this by applying it topically once or twice a day. The most rare fungal nail infection is the one on the top right, and this is the proximal subungual onychogryphosis, and this is where the matrix comes up to the end of the half moon, and it extends halfway back to the distal interphalangeal joint. And here, this half moon is infected first. So this is coming systemically from the patient. And this usually means that they're immunosuppressed. And this is sometimes the way HIV is diagnosed, because this tells you that there is a lymphocytic or a T cell defect. And the body's defense against the fungus is T cell. And so this is rare, but it is worrying. And it usually means the patient has a systemic disease. Next slide. These are not fungus. The nail plate abnormalities, if you look at Bowes lines, there is a line midway across the nail plate. And a fingernail takes 6 months to grow. One midway, I can say to the patient, what happened to you 3 months ago? Were you sick? And they say, well, I had pneumonia and I was really sick and I was off work for 2 weeks. And that'll give you a Bowes line. Self-inflicted is when a nervous habit, you keep pushing back the cuticle and you get a dystrophy in the nail, or sometimes this is when you go to a manicurist and they're really rough, but they cut away the cuticles. Random pits are seen in psoriasis, and that's immature keratin and it falls out. Pits in rows are sometimes seen, less commonly though, with eczema. Median cunicular dystrophy is continued trauma and sometimes chronic paronychia, inflammation of the nail fold. And chylonychia is spoon nails, and this is most commonly seen with iron deficiency, but infections, thyroid disease can cause these spoon nails. Inflammation of the nail fold, the one at the top is chronic paronychia, where it's rounded, you've lost the cuticle, there's some nail plate abnormalities. Acute is when it's painful, painful, painful. And it's usually secondary bacteria. And you need to treat gram-positives, negatives, and anaerobes there. And when you get a mucus cyst, these are the clear cysts that usually are found around the distal interphalangeal joint, mostly of the fingers than the toes. And if you drain this clear gel, it prevents a groove forming in the nail as the matrix tries to get under the mucus cyst or the generation of collagen. And about 50% of them communicate with the joint. And you can actually puncture the surface. And if you do it gently and you squeeze out the royal jelly, it's a clear gel. If you get bleeding, you've been a little bit too rough. On the bottom is nail clippings, and these nail clippings, the most fungus is in the debris underneath the nail. So if you clip the nail, make sure that subungual debris is there. And on the pink left-hand side, you can see the hyphae of the fungus, so that would be a positive microscopic examination. Next slide. These are nail color abnormalities. The green color, usually in bartenders, people that do domestic or janitorial jobs, and they get a lot of moisture around the nail folds. You get Pseudomonas under the nails. So hypochlorous acid or dilute white vinegar, dilute at 1 in 5, 1 in 10, can help you with this. And they need to wear gloves. They need not to push back the cuticles, and you may use an azole cream around the nail fold to get the secondary yeast and help you with the inflammation. They're anti-inflammatory. The second one down is not a bilateral melanoma, but it is stops and starts, tennis, squash, any kind of running, and you get hemorrhage under the nail. When you see Hutchinson's sign, the left lower one, and you can see, Andrew, maybe you can point at the pigment in the sideways nail there. And that's called Hutchinson's sign. And you know there's something wrong when the pigment branches out from under the nail fold. And this is a malignant melanoma. On the right side top, 6 months to grow out, and that's leukonychia or pushing back the cuticle. And if you go for the manicurist every month, you can see 5 or 6 lines gradually going up the interval of the nail. And if it's every 2 weeks, you might see fewer. And leukonychia, or the second one is yellow nail syndrome. And in yellow nail syndrome, the nails stop growing. And it's more associated with lymphedema and bronchiectasis and pleural effusion, lymphatic obstruction with the lymphedema. And the nails don't grow. Now, pigmented bands are more common in people of color, brown and black skin. They usually don't appear after the age of 50. Drugs like cyclophosphamide can cause that, as can trauma. For a melanoma, you'd look for feathering, irregular parts going out the edges, and you look for Hutchinson's sign, the pigment going beyond the nail fold or beyond the distal part of the nail, as you saw in the lower left-hand side. Next slide. These are thick nails. Pincer nail is when there's increased curvature and the nail plate grows in the middle. And when these get too high, they get very painful in the shoes. And the only way to get rid of the pain is to physically remove the nail And then most foot specialists will use phenol to obliterate the matrix and prevent another nail from growing. If it does, it'll be even worse than the first. Onychogryphosis is seen with arterial disease or neglect in the elderly, and these are the second and third picture are nails that haven't been cut for 2 or 3 years. And the reason they haven't been cut is because they're so thick, the patient can't get a nail clipper through them to cut them, and you need to see a professional. Psoriasis can also cause thick nails, but about 20% persons with psoriasis and thick nails have secondary fungus, but fungus on its own in the very last one can cause thick nails, especially when you get whole plate involvement. And it's the subungual debris you need to send away. And it's much harder to use treatment for those thick nails. Next slide. Here's an interesting slide that this was a higher incidence of gangrene and foot ulcers in patients with diabetes and fungal nails. And when you look at the incidence of gangrene without fungus, it's 1%. With fungus in this population, it's 4.8% fungal nails. For foot ulcers, 2.2, but with fungal nails, 6.2%. And gangrene plus foot ulcer doubles from 0.6 to 1.2%. And for a positive, you need either a positive microscopic or culture. If you're really suspicious, you might have to do the culture 2 or 3 times, but you need a healthcare professional that can order tests. This may be a nurse practitioner, maybe a physician, physician assistant, etc. Topical jubula takes 10 months. It's about 54% effective. Oral Lamisil 250 daily for 3 to 4 months gives you 70 to 80% clearing of fungal nails. But don't forget, they take 2 years to grow out. Oral Lamisil, a trick of the trade, is giving 250 milligrams for 7 days a month for 4 months. So instead of using 112 pills, you're only using 28 pills. And because the Lamisil is integrated in the nail at the level of the matrix, and as the nail grows out, it's still there. So you can often get the same result with 28 pills that you get with 112. And it costs a patient under $100 versus even generic in Canada, $350. Next slide. And this has led the International Diabetes Federation to recommend that onychomycosis increases the risk of developing both the diabetic foot ulcer and the amputation. So loss of protective sensation with either high pressure or poor circulation or structural foot deformities or onychomycosis, risk category 2. So this then puts it in a high risk for foot ulcers and amputation. Next slide. This is just the monofilament test. You only do it once until it bends in a C shape, and you do the first, third, and fifth toe, first, third, and fifth metatarsal heads, 2 sides of the foot and the heel, as well as the dorsum of the foot. Next slide. Okay, 3 components to neuropathy. Sensory, use the monofilament. Motor, structural deformities often occur, and you check reflexes. And you can get loss of the plantar reflex, which would be over the malleoli, or you do the knee reflex. Autonomic or nerve damage cause dry skin, and you need to distinguish this from fungus, which can also cause dry skin. The fungus tends to roll around the sides of the foot in a distribution that a moccasin might cover when you put a moccasin on. And so you look for the 3 components: sensory, autonomic, and motor. Remember the mnemonic SAM. Next slide. nociceptive and neuropathic pain. And patients with pain deserve treatment. I favor the 11 unit numeric rating scale. And 0 is no pain. 10 is like slamming your thumb on the car door, and 5 is a bee sting. And most people can live with the 3 to 4. For gnawing, aching, tender, and throbbing pain, we use acetaminophen. It's most useful in people over 65, or non-steroidal anti-inflammatories like our Advil or Motrins are associated with worsening of congestive heart failure. You can get kidney disease, and you can get GI bleeds. Acetaminophen is much safer. You have to lower the dose if there is liver disease, but 1 gram twice a day. And in Ontario, acetaminophen 500 is covered on the seniors benefit. Neuropathic pain is really burning, stinging, shooting, and stabbing. This is where we use the gabapentinoids, so Lyrica, or we use Neurontin as first line. We might use a tricyclic like nortriptyline as second line. And third line might be SSRIs, so antidepressants. It might even be cannabis, either topical or oral. For nociceptive pain that fails acetaminophen and non-steroidal anti-inflammatories, then you may go to narcotic agents, and we are getting away from using those. Next slide. This is the 60-second screen, and Hiskey Smart and Dr. Kadanga, working in wound care in the Kingdom of Bahrain, took the history, physical, foot, and neuropathy, and put where the referral should be. You can circle it, and the follow-up period. And you see the follow-up period. If there is nothing, the follow-up period would be 12 months, as it would probably be with previous ulcer and amputation. But if they've got a deformity, an ingrown toe, or absent pedal pulses, then the follow-up might be 3 to 6 months. And if they've got an active ulcer, a blister, a bad callus, you might want to see them almost immediately. And you have to be careful with the web spaces to address that maceration, because they're at high risk of getting a bacterial infection, a cellulitis, in the lower leg. And this is really important. And if the monofilament test is negative, they do need plantar pressure redistribution devices and an initial visit and 3 monthly visits. Next slide. And here you see the foot risk assessment and follow-up guide. And this is actually on the back of the screening tool, but we've just gone through them. Next slide. And this is the INLO assessment. This is more of an assessment than a screening tool. In step 1, you have to do a complete screen of both feet, the skin and nails, so there's 9 check boxes on each foot. Part 2, you have to screen for loss of protective sensation, 6 text box. Part 3, you screen for peripheral arterial disease, 7 check boxes. And part 4, screen for bony deformity and footwear, 10 more. So there are 32 check boxes, and then a score you have to add up. You're going to do this tool, it takes about half an hour. It's very hard to build this into busy schedules if you're going to do a screen. Next slide. Here you see a summary of the NSWOCC test. No monofilament or equipment. Testing for neuropathy does not include vascular assessment, does have an instruction session, no form to summarize, and it may be more geared to the lay person. And this is where I'll show you very quickly. You ask the patient to say yes or no, and you touch 4 toes.
Your doctor. If I can just have you rest back and make yourself comfortable. This might be best done on a couch, but it's perfectly adequate sitting on the chair like this, and I'm going to test your feet for sensation. And I'm going to do that by touching your toes, and I'm going to touch them very lightly. Okay. I'm not going to press or prod, I'm just going to lightly touch them. And I'd like you to say yes when I touch you, and I'm going to touch you in 6 points.
Yes. 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 Yes.
That's brilliant. You can open your eyes now. That's perfect. You could feel everything. So you haven't lost sensation. You haven't got neuropathy.
Okay.
Very
Thank
good.
you.
Okay, you can cut that. And so this is a very simple testing tool, but it only really tests for the neuropathy. I would recommend testing in my practice with the INLO tool, the simplified 60-second, the NSWOCC tool, another tool, maybe you could put that in the chat for us, are not applicable to my practice. So let's vote. This is something that you could save a limb and you could save a life.
And so while I keep it open a little bit here, we're about 60% are saying the simplified 60-second screen for the high-risk diabetic foot. The next most popular is INLO's 60-second assessment tool at about 24-25%. About 9 or 8% for the NSWOCC tool, and 8% are saying not applicable to my practice. Only 1% are mentioning another tool.
Okay, thank you. Next slide. Okay, you can make your own monofilament, fishing line, scissors, taper, ruler, paper, glue, and stapler. Next slide. So you cut a paper 10 by 5, you fold it in half. Next. You cut exactly 5 centimeters of 30-pound fishing line. You place the fishing line onto the paper. 4 centimeters should be sticking out. Next one. Apply the glue to the paper for security staple, and you have a monofilament. Next. Too short and perfect. Next. Let's look at strategies for psoriasis and atopic dermatitis. About 1.5 to 5% have plaque psoriasis, and it is most common in people 60 to 69. So you may see this in your wound patients. 1/3 can begin in pediatric ages, an upward trend in incidence and prevalence. And next slide. So there's the dry cracked skin. They're discrete plaques. You can draw a circle around it. When you get a scale, it's silvery. When you're itching and burning or sore, you may have scratched the scale off or partially treated. It may vary in color from pink to purple gray, particularly in people of color. And they can sometimes leave post-inflammatory pigment. Next. And in psoriasis, we start with topical steroids. We often use ointments. And then we use vitamin A derivatives, often combined with the steroid. Dova-Bet is a vitamin D derivative with the steroid. Protopic and Elidil are often used in the folds or calcineurin inhibitors. Coal tar has been used, as has salicylic acid, increases penetration. And petrolatum is occlusive. We sometimes use interlesional steroid, ultraviolet light. We have systemic drugs we use, and when they fail, and there's 10% of the body involved, they do a derm quality of life index, and you have to find people in the derm quality of life index with a score over 10% of the body, and they do a psoriasis area and severity score. And if it's over 10, and they've tried 2 of the systemics, they may qualify for a biologic. Next. And if you want to take a picture of this, this is the difference. Lotion is a powder and water. It's drying, good for the scalp. Cream is oil in a continuous water phase, so it's somewhat drying. An ointment is water in an oil phase. A patch is occlusive delivery of a topical agent. A paste is a powder in an oil. And a gel is in a powder in a lattice, and it shouldn't be compounded or the lattice breaks down and it's useless. Next one. And you can take a picture of this, but when you're an ordering physician, 1 times hydrocortisone is over the counter. So we'll mix 1.5% hydrocortisone powder and clotrimazole cream if we're making an antifungal steroid combination. 3 times is for the face or folds. 6 times is for the hands, feet, trunk, or extremities. You want to take a picture of this if it's useful to you, do it. 9 times is the palms and soles, and 12 times is resistant when it's on the palms and soles. But you have to stop using things that are too strong for the area that you're applying it to. Next one. And if I was writing a prescription for this psoriasis, Andrew, press the button. Use betamethasone 0.1, which is the 6 times, because psoriasis is thick, 5 out of 7 days, and this would be for the back and the knees. I would use Dovabet ointment 2 out of 7 so that I get the vitamin D derivative as steroid sparing. And I might use doxepin, which is a tricyclic, but a great antihistamine on the Ontario drug benefit and some other provinces, and use 10 to 30 milligrams at night. But to be an antidepressant, you have to have 75 to 150 grams. Newer antihistamines, Blexten, Rupall, Reactine, are also useful without causing as much drowsiness. Next. Creams, and you should take a picture of this. Moisturizers are a maintenance therapy. And cream bases without allergens are perfume, Cetaphil, CeraVe, Galaxo. Ointment bases are Vaseline or Eucerin, but because it's a wool wax alcohol, you don't want to use it in atopic people. Those are people that have asthma or hay fever or eczema. And often the eczema can start as early as the 2nd week of life. Emollient bases, Lipicar is much thicker and would be a thicker moisturizer for really dry skin. A humectant, instead of preventing insensible losses, binds water on the surface of the skin. They're part of the natural moisturizing factor, and ceramides, as in CeraVe, are actually structural proteins with some humectant properties, as do urea, lactic acid, and glycerin. Next one. Here's 2 different legs. They look similar and circular. The left one is more acute. The right one is more chronic with discrete plaques. And Andrew, press the button. And nummular eczema is on the left, and psoriasis partially treated is on the right. And the nummular eczema, there's individual papules that coalesce into spots. Next one. And take a picture of this, but it's education, avoidance of trigger, and using moisturizers. And I showed you the hydrating versus the emollient. Barrier products have really gone. Topical steroids, the calcineurin inhibitors, we've mentioned Protopic and Elidel. Eucrista is a new one on the market. It affects a different type of inflammatory response. The traditional antihistamines are more sedating and help itch at night. Atarax, Benadryl, Doxepin. Antimicrobials, Staph aureus is often there secondarily. Doxycycline is the preferred tetracycline. Azithromycin, the preferred erythromycin, or trimethoprim. And the studies are small. We don't have large studies like they do in cardiology. Next. Here are 4 RCTs. An RCT educating parents, decreased severity of eczema in infants. Emollients improve treatment response with topical corticosteroids. A quantitative assessment combining bathing and moisturizing. And this is an important one. Bathing plus no moisturizer may compromise hydration. Bathing with moisturizer provides modest hydration, but applying moisturizer alone gave the greatest benefit. So de-emphasize the bathing and emphasize the moisturizer. It should be put on 1 to 3 minutes after bathing while the skin's still damp. Pilot study with emollient therapy for primary prevention of atopic dermatitis, 22 neonates at high risk, 20 were evaluable, and 3 out of the 20 developed atopic dermatitis, but just using moisturizers on a regular basis prevented it from happening early on. So these studies tell a neat story. Next. Here's the atopic skin signs: dry skin, scaling skins, fissured skin, exudation or weeping skin, and bleeding skin. Next one. What's the most likely diagnosis? This patient had bilateral leg eruption, painful and itchy, was using lanolin and triple antibiotic cream and compression. I think this is bilateral cellulitis, contact allergic dermatitis, psoriasis, Stacey's dermatitis, or acute lipodermatosclerosis. What do you think?
I'll just mention the same thing. If you're seeing just a photo in your poll on your end, you might need to scroll down just a little bit to see the 5 different options below. I'll leave this open for a couple more seconds here. And as we're getting close to half participated, it looks like we are at 46 to 47% are saying stasis dermatitis. The next highest with 23% is contact allergic dermatitis, followed by 15% saying bilateral cellulitis, 9% saying acute lipodermatosclerosis, and 7% with psoriasis.
Okay. Acute lipodermatosclerosis is usually dermal with no epidermal component. When we look at stasis dermatitis, it's very definitely a component here, but the main component is contact allergic dermatitis. Psoriasis would have scale rather than crusting, and bilateral cellulitis at the same level on both sides is really very uncommon. And let's look at the next slide. Patient was not better with 1 week of intravenous antibiotics, duplex Doppler negative for deep vein phlebitis, history of venous leg problem using a number of topical antibiotics and moisturizing creams under a tensor or elastic bandage. Next slide. Contact dermatitis, about 80% are irritant, 20 allergic. Exposure to chemicals in the environment. Patient was using triple antibiotic cream, neomycin, bacitracin, gramicidin, along with Nivea cream. There is a coexisting component of stasis dermatitis. Next one. And ordered betamethasone 0.1 ointment. Stasis dermatitis and edema treated with zinc oxide paste boot. And Coban original, not Coban 2 or Coban 2 light, applied at full strength, the Duke boot. Dramatic improvement. Usage tests to the creams applied to the forearm, both were positive for lanolin and bacitracin. Patch tests were applied 2 weeks later and confirmed that. Next, let's look at the importance of sun protection. Basal cell carcinoma is the most common cancer. The one on the top was in a lady that was on home care for 8 years. We biopsied her. She had lymphedema. This is a basal cell treated as a wound. And the bottom picture is what looks like granulation tissue, and that's actually a basal cell. And, when they're not 30% smaller by week 4, and they won't heal by week 12, start thinking about an interprofessional consult, a biopsy, doing specialized testing. And you see another more classic basal cell in the middle of what appears to be a wound. Can you show the round donut Andrew, in the left upper picture. And right there, that's the basal cell. And it's sun-exposed skin, lymphedema. There's a superficial type, an ulcerative or a nodular type, one that looks like morphea, so it kind of blends in, sclerosing. It looks like scar tissue, and there's even occasional pigmented ones. Next one. This is what a squamous cell looks like. And you often have some keratin, some crust. They occur on sun-damaged skin, edges of skin graft, old burn scars, osteomyelitis, sinuses, and they're much more common with organ transplants because of the immunosuppression. Natural history is variable, and staging is built on diameter, invasion, whether it's seen around the perineural area. Next one. This is what a mole versus a melanoma looks like. And a mole, we're not born with, we don't die with them. They come in late childhood, early adult, very occasional congenital nevi. And you're looking for the asymmetry, borders that are irregular like a ski slope color. Black is too much melanin. Blue, by the Tyndall effect, it's deeper. White, it's regressed. And red, it's inflamed. And diameter, greater than an eraser on a pencil, or if it's evolving. Next slide. What do you think this is? The eye sees what the mind knows. This is a, if you like, a heel ulcer, secondary to pressure. What do you think, or what's wrong with this picture? Maybe you can put something in the chat and see what do you think is going on here.
Maybe melanoma.
Yeah, very good. It is. And there's a secondary deposit, and the biopsy, and this was a patient we saw in South Africa in one of the IWCC courses, and the biopsy did show a melanoma of the foot with that secondary lesion. Next one. Sunburn, sun damage, retinal damage, and using artificial lights to get a suntan. Lots of people end up and emerge if they don't protect their eyes. Next. And sunburns, cool the burn, protect from re-injury, treat pain, drink water, but also you need electrolytes and avoid popping the blisters. And seek medical attention if there's symptoms of infection, blisters larger than 5 centimeters, or pain gets worse, especially hands, feet, face, or genital areas are infected. And a sunscreen's a log function, so a 15 gives you 93, a 120 gives you 99, a 60 gives you 98.5, and a 30, 97. The biggest problem is you put on about half of what you need to get the sun protection factor. Just remember the SPF is only UVB. UVA goes through the car window. It adds to the carcinogenesis of UVB, but it causes the dark spots you may have on the back of your hands or on your cheeks, especially the left cheek if it's coming through the car window. Apply sunscreen 30 minutes before. It's got to be the first and only thing you apply. Use sticks around the lips and the eyes. Avoid excessive exposure between 11 and 4. Hat with a 7 centimeter brim and protective clothing. But if you're avoiding the sun, vitamin D3, 2,000 international units in the winter, and that's after Thanksgiving, and 1,000 in the summer after May 24th. Because it's fat soluble, it should be with supper, like vitamin A, E, and K. Next. There are some sunscreens you can take a picture. It's either a screen or a physical blocker, which has less chemicals, but it's got zinc oxide or titanium usually. And look at the UVA and UVB coverage. Next. Okay, we have assessed tools and used the high-risk diabetic foot to look at foot care and foot exam. assessed appropriate management for psoriasis and atopic, and reviewed the importance of sun protection. And do we have something in the chat?
Absolutely, we do. Well, first of all, thank you again for going over this. This is fantastic. I've tried to sort it out as best as possible here. We've got a few initial ones, and I'll remind anyone if you do have questions, do put them in that Q&A box. So rather than the chat, you can
Yes,
use the
sorry, I should have
no,
said that. Yeah.
no problem. Chat will work too. I've been catching them as they come as well. So someone was asking here, when nail fungus is suspected, do current guidelines recommend treating empirically without nail sampling, or is testing still preferred?
If you're going to use systemic agents, you should do a test because there are 22 agents or 22 different conditions that cause
Mhm.
funny nails, and it's not always fungus. And although it may look a lot like fungus, a lot of them aren't. And using a systemic agent would be a bad idea.
Fair enough. And so, kind of a follow-up, I guess, to that is someone was asking about terbinafine. Is it now considered safe to start without baselines liver function tests, or should clinicians still order them before
I
prescribing?
order them,
Yeah.
and if they've had the liver function in the last 6 months, I don't. But if they don't, I do. Terbinafine is Lamisil, and about 2% of people get hives. You stop it. 5% stomach upset. You take it with supper. 1 in 800 a temporary loss of taste. A little bit more common with diabetes. You stop it. The liver function abnormalities are 1 in 10,000 to 100,000. And so if they have a baseline within the last 6 months, I don't do it. If they develop any symptoms, then I will measure liver function test. And I was part of that drug coming to market in 92. I was one of a dozen investigators, and I've had a lot of experience with the drug. And it's a good drug. 70 to 80% of people get cleared of the fungus with 3 to 4 months. The topical agent, Jubula, I would allow people to use topically without a liver function and without monitoring. But otherwise, you need a KOH that shows fungal elements. 20% of people that are tested, 20% have just growth of T rubrum, and you need one or the other, okay, before you use an oral agent.
For infants, they have this one person who has a 2-month old with eczema on the legs. There's a family history of all their family has eczema. Do you find that it's appropriate to use topical steroids at that age?
Yes. And moisturize, moisturize, moisturize. The topical steroids are for the red areas. On the face and folds, the two F words, I would use the calcineurin inhibitors. And at the hospital for sick children, they start at 3 months with Elidel or Protopic. And Protopic, they use 0.1, even though the recommendation is for 12 years and over. My daughter is a pediatric derm at Catherine Sibbald at Sick Kids, and she has no problem using point 0.1. And when I do it, I write as per sick children's. And then my topical steroid would be other than the face or folds for most. Very occasionally, we have to use it, and we would use 1% hydrocortisone initially. If that doesn't work, we go up to 3 times, which would be either Desinide or it would be betamethasone 0.05. So that's the half strength. But
Perfect.
much more important to moisturize. And it's moisturize, moisturize, moisturize.
And on that same topic, I guess someone was asking if you could just clarify or briefly touch on when it's more appropriate to use a humectant versus an emollient. I know it's a full
Okay.
topic for another day too, but if you wanted to
Yeah,
briefly touch on that.
that's a good question. And sometimes humectants will burn and sting, and you shouldn't put it on if there's open skin. You shouldn't put it on if it's really dry and it burns and sting. And if you have a bath, even if it's a very quick bath, pat the skin, and while damp, put them on, it's best. And that's the urea, the lactic acid, the glycerin, or the ceramide. The emollient forms a barrier. And in some atopics, they don't like ointments or something really greasy like Lipicar. And they do well with CeraVe or with Cetaphil. And the creams for most of the body, if you're on acne-prone areas, you might want to use the lotions in those preparations. But the Protopic and Elidel under gloves and hand eczema at night, when you use that at night and the steroid in the morning, you get the best results because the big defect is in the barrier function, and the Protopic and Elidel give the barrier back. In Ontario, you need limited use 383 because these things are about $150 a tube for the Protopic and Elidel. The topical steroids are relatively cheap.
And we had a really interesting question here coming in for Indigenous patients. This person, they often see a brown streak laterally through the nail can be common in non-Indigenous patients. How concerning would that lateral brown streak be in terms of possible melanoma?
Okay, if there's no Hutchinson sign, it's somebody under 50 and it's regular, none. And just remember drugs and so forth can. Otherwise, it's a nevus of the nail matrix and it's benign. But if you see the feathering, somebody over 50, they're not on a drug that can cause it, it's irregular, or you have Hutchinson sign, that's when. But in people of type 5 or type skin, brown or black skin, they're much more common than in white skin, Fitzpatrick 1, 2, and 3, and even olive skin, Fitzpatrick 4.
And I've got a lot of questions in the chat. There were some questions related to last webinar we had last week, and some people were saying they missed the beginning and want to watch this back. I'll remind everyone that we are recording today's webinar, so we will be able to put that up. Again, just give us about 2 business days. We'll have it up on our website at nswoc.ca. We'll also send the link to the recording in the email that you're going to get with your certificate of attendance. But if you had questions from last week's webinar, you can also go watch that online too. All right, just a couple more here. I know we're over time, so thank you for all of you for sticking on with us. This is all great, great information here. Can you remind us what the drainage would look like if fungal infections appear on the skin? Would it ever be green?
No, that usually, okay, would be Pseudomonas secondarily invading, and that's the pyrocyanin that comes from Pseudomonas. And if you had a Woods light, you could look at it, and it does fluoresce. There is a green fluorescence from a fungus that affects the hair, but not the one that you would see. I mean, we're really concentrating in this on the leg and foot. And so you don't generally see a green color with just fungus. That means Pseudomonas in there secondarily, and that means get out your povidone iodine.
Perfect. Okay, well, I think we'll pause it there. I know there's some great questions. We could probably talk about this all day, but we had a great comment from Trish who says her question was, "Can you present every month?" And Dr. Sibbald, I don't think there's a month gone by where you haven't done some sort of presentation, I'm sure. But we are going to be doing, as I said at the beginning there, we have a full series or this series is going to be continuing into 26. We already have the dates for next week as well as one for the end of January. We've also added placeholder dates beyond January going into June. So for that first half of 26, we've added a placeholder. It's all on the exact same link that you've used to sign up for this webinar today. We're going to continue to send reminders, but you can save the date, register for those in advance on Zoom, and add them to your calendar. Dr. Sibbald will definitely be on for a couple of those, not every month, but we will have you on for a couple more. So thanks again for your time today and sharing your expertise, Dr. Sibbald, and we'll hope you have a great holiday. We'll see you back in 2026.
Okay, sounds great, and a great holiday to everybody else, and enjoy.
Good night, everyone.